Okay, great. Thanks so much for coming this early in the morning. I'm on East Coast time, so I'm primed. And I have my whole family here because, as you heard from Letta, I went to college and med school in the Bay Area. My wife did as well too. So we're excited to reconnect with old friends. And my kids last came when they were very young, so this is kind of a first experience for them. These are my disclosures. Nothing relevant to this talk. But as you heard, I went to Cal. My wife went to Stanford, so we had this internal kind of rivalry. I guess I'm the only one that cares. My wife doesn't seem to really care that much. But my kids, because mom went to Stanford, they only wear Stanford gear. I took them to Cal yesterday, but they didn't care to buy anything. So anyway, but now I've lived, more than twice that amount of time in Boston. I have to navigate a separate rivalry. I grew up in Los Angeles, so I have to navigate living in a city with a bunch of Celtics fans. And my friends from medical school, when I saw a bunch of them, they were horrified that I could sometimes root for the Celtics. But I've been here. My kids are New Englanders. And this is a map of Greater Boston, and you see on the intro there are lots of different organizations and centers that I'm a part of. More recently, Mass General, the Brigham, and all the community health centers within Partners Healthcare. This is all now called Mass General Brigham, and actually in cardiology, cardiac surgery, vascular surgery, they're all in one single entity across all of these at Mass General Brigham. So I've highlighted both. My clinical practice is at MGH here, and the Brigham is here as well, and we do a lot more coordination compared to before. My lab is, interestingly, it's split between both MGH and the Broad Institute of Harvard and MIT. MIT is just right here. This is a freestanding human genetics research institute that's well known for creating genomics technologies, assays, gene editing, and a lot of advances in data sciences. And we leverage a lot of that scientific ecosystem for the work that we do. I do spend a lot of my time teaching, actually, for first-year medical students in human genetics. And then a new role that I took on is in something called personalized medicine. It's an entity within Mass General Brigham that is responsible for our biobank, which I'll tell you about in a minute, and then also in-house genetic testing, which will become relevant later in this talk. Now, I'm going to focus on just kind of one aspect of the lab. I would say, it's probably one of the more important aspects of the lab. But we use human genetics broadly as a tool to understand cardiovascular disease. I'll be speaking for cardiology tomorrow, actually, where I'll go through lots of these different examples and how genetics has advanced many areas in our understanding of cardiovascular disease. One of the reasons why I focus on this and why there is a distinct advantage is that when you look at an exposure and an outcome, there are many different things that may explain that relationship. Sometimes that can represent a causal relationship. Most of the times, those are just correlative and not necessarily telling you anything inherently causal related to that outcome. Whereas human genetics, as an exposure, that exposure is fixed. So if there is an association or a relationship between that static exposure and an outcome, that can tell you something really important and fundamental about what might be causally influencing that condition. As a separate opportunity from human genetics is that those features can also be used to inform risk prediction, which I'll talk about in this talk. And this may be, still seemingly esoteric. Most folks in this room may not have yet experienced this in their clinical practice. I know many folks at Stanford have come across this. I certainly come across this in my clinical practice. And so much so, just a few years ago, we put together a scientific statement. It was actually led by a Stanford resident at the time with me, Jack O'Sullivan, who's in Ewan Ashley's group, and Ewan is on this document as well, because increasingly we were seeing folks taking a lot of the data that they were generating about themselves and using a wide variety of different tools and other commercial assays to try to understand genetic risk. And so this document was really intended to describe the state of that. One of the major interesting features of genetics is that it is widely available to our patients. As opposed to, as I said, there's unique features that it's a static exposure, and that has some separate advantages, has some separate challenges. But many of our patients can go out there and pay to have pretty broad human genetic profiling. Funny thing is, they can't go out there and get their lipids checked, for example. But for human genetics, they can generate this data. And this is already a little bit outdated, but you can see there's already tens of millions of Americans who feel like human genetics can be helpful and important. And among the motivations are to understand disease risks. Now, as researchers in the field, we are also generating a lot of data to understand the genetic architecture for a lot of different traits. GWAS is genome-wide association studies. So separately, people are paying as consumers, and then we are also paying via sponsors to genetically profile research participants. And then over the last 10 years, there has been a substantial growth in national biobanks as well as healthcare-associated biobanks. I said earlier we have one at Mass General Brigham. This is already outdated as far as the numbers, but this shows some of the major biobanks that are out there. Now, our biobank now today is about 154,000 of our patients that have been recruited. They've all been consented for genetic analyses, consented for full electronic healthcare record analysis. They've also been consented for callback. You can see here, a little bit hard to see that obviously this all clusters around New England. We have the largest healthcare system in New England, but it is based in the greater Boston area. So most of the patients are in the Boston area. And this is kind of that same map that I showed before. And these are genetically similar individuals. And an important thing here is that when we do these relational analyses of genetic associations with outcomes, is that the genetic alleles are not uniformly distributed across different environmental features, environmental contexts, and other contexts that might influence why somebody might get disease. Cluster 0, which is actually the dominant cluster of genetic similarity, are individuals of British ancestry. And they cluster kind of around the area actually where MGH is, and then around where Harvard Square is. And these are some of the initial sites of colonization in the greater Boston area. And these are a wide variety of other groups. But you can also do interesting things here. This is actually looking at effective population size for this cluster 0, and then comparing it to British individuals who live in the United Kingdom. This is using the UK Biobank. And you can see these actually a reduction in population size. This bottlenecking feature is already, these are genetic signatures for the initial founding of Boston, New England, and the United States. So lots of things, unique things that we can do within our homegrown biobank. And I'm happy to talk about other examples as well. So as it relates to this, this topic of genetic risk prediction or using genetics to inform disease, we do a lot of this today, in cardiology. This is another scientific statement led by Karen Musunuru, describing genetic testing for inherited cardiovascular disease. And it's largely focused on understanding the etiologic diagnosis of a patient in front of you who has cardiovascular disease or suspected inherited cardiovascular disease. And then for asymptomatic individuals, usually family members in the form of cascade testing. In my world, for coronary artery disease, the canonical monogenic condition is familial hypercholesterolemia. This is about 1 in 250 individuals. This is roughly similar prevalence for cystic fibrosis. These individuals in general, if they have very high cholesterol levels, and as a result, substantial increased risk for premature coronary artery disease. The molecular defect for about 90% of them is a defect in the LDL receptor. The LDL receptor is a cell surface receptor that is responsible for detecting LDL particles, endocytosing LDL particles, and is also important in the feedback loop for cholesterol synthesis, since most of the cholesterol that is circulating in the body is being produced by the liver. And so if the LDL receptor is dysfunctional, the liver does not sense that there is substantial cholesterol. So in addition to not clearing away LDL particles, it starts to overproduce cholesterol as well. The molecular characterization for that Mendelian condition is very important in our understanding of the role of cholesterol for cardiovascular disease, but we do genetic testing sometimes for familial hypercholesterolemia. And actually, even though this was known for many years, the Nobel Prize for these insights was awarded in the 1980s, it's only more recently that we've started to do genetic testing. And that's because now we have done large population-based analyses to really better understand the prognosis related to familial hypercholesterolemia. This is a study that we did a number of years ago, that if you look at individuals who have hypercholesterolemia, and for the different levels of individuals, regardless of their etiology, and you look at those who have high, moderate cholesterol levels, if the reason that they got to high cholesterol levels was because they had familial hypercholesterolemia, that substantially accelerates or accentuates their risk for cardiovascular disease. This is a very similar study that was done in Europe. And beyond that, this is kind of around the exact same time that PCSK9 inhibitors were approved by FDA and were coming onto market. These were substantially more expensive compared to the medicines that we already had available to us in the form of oral pills, statins and some of the non-statin medicines. So that was often formed the basis for why individuals were getting genetic testing. Now, if you go back and look at individuals and with familial hypercholesterolemia and how they're treated, because there's still a fair amount of heterogeneity in how these individuals are treated. Individuals who have FH, and if they happen to be treated by statins versus non-statins, obviously there's a lowering of their future cardiovascular disease risk, but the hazard ratio is pretty substantial, about 0.56. In a standard randomized controlled trial for statins, the average hazard ratio is about 0.75, 0.8. And this has caveats, right? This is using real world data. There are many reasons why people are prescribed statins. There are many reasons why people aren't prescribed statins. But just recall this metric because I'll come back to it. This does form the basis of our understanding that suggests that individuals with FH, obviously because the major driver for why they're getting cardiovascular disease is because they have really high cholesterol, you would want to make sure that you focus your efforts on lowering their cholesterol. And this retrospective analysis suggests that they are more likely to benefit from this approach. Okay, we'll come back to this notion. Okay, so a lot of people have FH. Most people who get cardiovascular disease don't have FH, right? Is there a role for using human genetics beyond FH? And there are many different reasons why to focus on this. Cardiovascular disease continues to have the dubious distinction of being the leading killer in the US. Cancer is actually a very close second. And you could say, hey, this curve looks pretty good because it's not continually going up. And I agree that that is good. But importantly, this curve, which is cost attributable to cardiovascular disease, is also continuing to go up. There's a lot of public health advances that led to this plateauing. Around this time, this is the Surgeon General's report on smoking, on tobacco smoking for cancer and cardiovascular disease. There is an increased understanding and discovery of traditional modifiable cardiovascular disease risk factors. And those were, instrumental in this curve not continuing to go up, but has remained actually at a very high level. And because people are living longer, there are more individuals, everything costs more, the costs attributable to this are continually going up. And you could say this is, for all intents and purposes, might be a top reason that we should really focus on how do we, understand cardiovascular disease towards preventing cardiovascular disease. Okay, so, the cholesterol guidelines, prevention guidelines, and their earnest, kind of similar to its current form, have been in place since about the 1980s. Okay. This is an early figure from the Framingham Heart Study, and there's similar figures from other similarly sized epidemiological studies describing these initial risk factors and their correlations with cardiovascular disease, blood pressure, cholesterol, cigarettes, and blood glucose. And after many years, have been shown to be causal factors as well, too. Now, despite those initial observations, now about 50 years later, we're kind of using the exact same risk factors. That's not bad, but for many reasons, we're not really advancing because we're using the exact same heuristics. It's all largely around 10-year risk estimation. And this is a really nice mathematical exercise, is using the pooled cohort equations. Now, if you take each of these are deciles of age. These are individuals in their 40s, individuals in their 70s. What largely determines their risk is how old they are. And if you go increasing levels of each of these risk factors, the sweet spot where you would cross a clinically recommended actionable threshold are really individuals in middle age. Okay? And the challenge with that is that you're really prioritizing based on age. And for 10-year risk estimation, that's not inaccurate. Actually, most people don't realize that for 10-year risk estimation, you pretty much get all the way based on age and sex. And the traditional modifiable risk factors will move it a little bit, but most of that is really determined based on those features. Now, atherosclerosis does start early, and there aren't great data sets to really understand how early it starts. Probably the best is data sets from autopsies of US soldiers that have been killed in foreign wars. Now, the prevalence of atherosclerosis on those autopsies does vary across each of the wars, just because the prevalence of smoking has reduced over years across US soldiers. But these are folks that are healthy and well in their 20s that are being killed for usually trauma, not related to medical conditions. Okay. Prevalence of atherosclerosis is about 10%. Now, most of those individuals don't have traditional modifiable risk factors. If they do, the prevalence of atherosclerosis does go up. But most of the atherosclerosis, that's that numerator here, is happening in individuals who don't have traditionally recognizable modifiable risk factors. Because the prevalence of those do increase later in life. But about 11%, 1 in 9 individuals, does have atherosclerosis in their 20s and they don't have modifiable risk factors. Okay, so using our current tools of age and sex and modifiable risk factors, you would not be able to detect the bulk of atherosclerosis that is starting earlier in life. Now, there has been foundational work from Framingham and others that suggests that family history might help you understand what those early factors might be, information that is knowable before the onset of clinical risk factors. Now, if cardiovascular disease happens in a younger parent, in a parent who developed cardiovascular disease at a young age, so that's man less than 55, woman less than 65, independent of traditional risk factors like LDL cholesterol, that's about a 2-fold excess risk for that individual to get cardiovascular disease, and pretty similar for siblings as well, too. Now, those observations do form the basis for why we then do genetic studies to understand whether genetics does play a role for coronary artery disease. This figure is a little bit outdated, but what it's intending to show is that the different gene regions that have been mapped to coronary artery disease. And a genome-wide association study, which is the study that is used to kind of get this kind of plot, is relatively simple in its exercise. We're taking technologies largely similar to what direct-to-consumer companies are using, where there's an array of about 1 million genetic variants. And those genetic variants are selected because they're commonly varying across the population, meaning an allele prevalence of greater than 1%. And there are 3 billion base pairs. It's very expensive today to still do a profiling of all 3 billion base pairs. Maybe in 5 years we'll be doing that much more routinely. We do it more and more. But we can fill in some of these gaps by using profiles of 3 billion base pairs and fill in up to about 10 million genetic variants. Okay, so these are common genetic variants. This is not like familial hypercholesterolemia. Those are happening, those are often private to an individual, private to a family. There are some examples of recurrently observed FH mutations. You're not going to be able to detect that with this kind of technology. Okay, so 1 to 10 million genetic variants. You're looking at the allele frequencies in individuals who have coronary artery disease, the allele frequency in individuals who don't have coronary artery disease, and you're looking at the relative enrichment in cases relative to controls. And then you can assign a test statistic for that difference. And it turns out there are many regions of the genome that are associated with coronary artery disease. Today is about 300 plus, and that list is continually growing. Many of them do show pleiotropy or also association with traditional cardiovascular disease risk factors like lipids and blood pressure. Turns out about half of them do not. Actually, trying to understand why those half don't develop cardiovascular disease is really challenging. Just people like Paul and others spend a lot of time trying to figure out why that is, because there is often not an initial hypothesis for that. We'll talk about some examples tomorrow if people come. Okay, so you don't need to know any mechanisms related to any of those features to ultimately develop a risk predictor. We can take all of those features, we can say, okay, of these 300 gene regions that have been enriched in cases relative to controls, for the patient in front of me right here, if I profiled those 300 gene regions, how many of them have risk alleles that are enriched in cases relative to controls in a genome-wide association study? That's kind of the simplistic form of these polygenic risk scores, where every site has basically 0, 1, or 2 copies of a risk allele, right? Because at every site you have 1 chromosome from mom, 1 chromosome from dad. And so the score can be from 0 to 600. What has changed over time is that we know that as we do larger and larger genome-wide association studies, many of these signals that are not genome-wide significant do become significant. And so we can use Bayesian approaches and training and some other data sets to prioritize some of these genetic variants that are not significant. And so often these scores can span, 1 million or so genetic variants. And that also leads to improvement in those scores. That's kind of the current form of these so-called polygenic risk scores. This is not specific to coronary artery disease. Turns out most traits are heritable. To express a phenotype, you need the genes, right? And there is genetic variation that occurs. One thing I think that gets missed in these kinds of presentations is that if, for the person sitting next to you, on average, are 99.4% genetically similar. So really, we're talking about the genetic variation that is on the fringe. And it turns out that variation at each of these genes, near each of these genes that influences the regulation and expression of these genes, still does have substantial influence ultimately on the likelihood of developing a wide variety of traits. So all of these traits, all cardiovascular conditions, do have a heritable basis. Coronary artery disease has much more maturity, I'll say, in the field, but each of these lists are growing. And many of the folks in the room, we contribute to a lot of these efforts. Just call out a couple examples. Derek Claren was a vascular surgeon here. Derek was a former postdoc of mine, is now in industry. And then Aaron Small, who is a postdoc of mine who's now going to become a cardiologist at the Brigham, has been leading a lot of efforts in aortic stenosis, a condition that actually occurs much later in life. So Aaron actually just had a paper accepted at Nature Genetics that now has about 200 gene regions, which I find fascinating for something that largely manifests in the 70s and 80s. Anyway, we won't talk about that right now. But you can develop these scores for risk factors themselves. We do a lot of work in the genetic architecture of lipids, and others have done this for blood pressure. You can develop these polygenic risk scores. And interestingly, these do influence risk for cardiovascular disease that are outsized the measured risk factors themselves. This is actually very similar to familial hypercholesterolemia that I showed you before. For individuals who have FH, their risk for cardiovascular disease is greater than somebody who has a very similar LDL cholesterol. The hypothesis being is that those exposures, those atherogenic features, are starting early in life and compounding. Turns out that's actually very similar for common genetic variants as well. And as you would expect, these polygenic factors, these common genetic factors, do predict the onset of the clinical factors themselves. Can be a really important tool potentially for primordial prevention. This is an example for incident hypertension. Okay, so how do these scores perform in the population? Just coming back to coronary artery disease. I told you about family history as a major reason why we have, as a field, looked at coronary artery disease and other cardiovascular conditions, at least characterizing the genetic architecture. Now, as far as a risk predictor, is it going to tell us anything more beyond just ascertaining a family history? Now, as you would expect, those two features are correlated, but it turns out it does stratify risk for cardiovascular disease among individuals who have a self-reported family history and those who don't have a self-reported family history. And there are many reasons why people don't have family history. Sometimes various other risk factors are recognized earlier. There are other features that influence the likelihood for developing coronary artery disease. And a self-reported family history, and even one that is ascertained in the office, can be challenging. But this also shows that there are many other heritable factors within a family that lead to familial enrichment for a condition that don't necessarily have to just be genetics, right? The shared alleles often can go with shared lifestyle factors, healthcare access, income, food availability, things that we know also influence coronary artery disease. So these are complementary sources of information, but the polygenic risk score is very much quantifying the genetic contribution for coronary artery disease. Now, one of the metrics that is often used to understand clinical utility, and I have a challenge at least in that equation, but anyway, that's what's often used. The C index is the metric. This largely relates to the overall prevalence of a risk factor, the likelihood of that risk factor being abnormal in cases and not being abnormal in controls. And then that is summed in this kind of metric. Okay, C index of 0.5 is a flip of a coin. Okay, so let's look at the traditional risk factors. Let's look at a polygenic risk score, because people often say, oh, the C index is not great. So we should go back and benchmark it to things that we use, right, for screening tools like the traditional cardiovascular disease risk factors. This is done in the UK Biobank. And, these all are, obviously better than the flip of a coin. This is for 10-year risk prediction. As I said, age and sex are pretty good. But these are what you get. And this is what you get for a polygenic risk score, which is similar on par, maybe a little bit better. Obviously, for risk prediction, today, we don't look at the clinical risk factors in isolation. So if you put it here together, and then you add in a polygenic risk score, there is still additional information that is being provided here. Now, what about like how we practice today, right? These are prior studies are in agnostic epi cohorts. This is in US biobanks. The Partners, as I said, was the name of our healthcare system, now Mass General Brigham. But these are kind of 3 biobanks in their earlier phases, just because these numbers are smaller, they're all much larger. And we said, okay, maybe we're all expert clinicians. We take better family histories. We're aggressive in prevention. Is there still a signal? And it turns out there's actually a very similar signal. The metric here, odds ratio, is a prevalence of coronary artery disease per standard deviation of a coronary artery disease polygenic risk score. And surprisingly, across each of these different contexts, each of these different healthcare systems, despite what we do today, you do have a risk signal for coronary artery disease, meaning that it's not something that we are detecting within our contemporary clinical practice. Now, if you look at individuals with FH, obviously individuals with FH, you can kind of have a sense that somebody has FH because they have higher lipids. That is the reason why they have FH and the reasons why they have high cardiovascular disease risk. But individuals with a high polygenic risk score, even though there is pleiotropy with some of those risk factors, there isn't a lot of pleiotropy. So what that means is that individuals on average have about an 8 milligram per deciliter higher LDL cholesterol if they have a high polygenic risk score, but that's not really that clinically detectable. If you look at the bins of statin eligibility based on a pooled cohort equations, if you're high or not high, you would look exactly the same based on traditional cardiovascular disease risk factors. So there is a risk signal, and today it's not readily detectable. And that's probably why there is a risk signal. And a lot of this work was done and started just because of the most recent iteration of the prevention guidelines, the cholesterol guidelines, was advancing this concept of a risk-enhancing factor, which are factors really beyond traditional risk factors that do up-classify a risk. And so we're really prioritizing a threshold and a cutoff or a heuristic that is similar to this. Because I think, especially when you're introducing new things in medicine, it is always safest for people to understand and accept if you start to align with what clinical practice is today. And so, when we looked into this to really see how much is this actually going to influence practice, we looked at those where there is some clinical equipoise, borderline intermediate risk, where there is a reasonable recommendation for a statin, but clinicians can use additional factors to up or down classify risk, at least at minimum with these risk enhancing factors. We said, okay, many of these folks probably already are going to be prescribed statins. How many really would this actually change? So we looked at those individuals, subsetted those to those who had a top 20th percentile for a polygenic risk, which is about a 2-fold increased risk, and then who weren't already prescribed on a statin. And we said in this context of using as a risk enhancer is about 4% of individuals where you might newly recommend a statin just based on this information, right? So not, reasonably conservative. Now, one of the challenge with this space is that, with any risk predictor, you're always going to perform best when the training data when the target population is most similar to that training data. And most of the training data, as Letta set up, is not in diverse cohorts. It's largely in individuals of European population. This is a great figure. This comes from a colleague of mine at MGH. This is now a heavily cited figure, is that this represents the accumulation of human genetic data relative to the world's population for each of these different ancestry groups. And you can see it's overwhelmingly overrepresented of European ancestries. And that's because most of the initial investment in these data sets have been in data sets where there can be an earlier return. And most of the original epidemiological cohorts have been in individuals of European ancestry. A lot of the investment in this research comes from European or European dominant countries. What this means is that if you take a bunch of different polygenic risk scores and look at their performance relative to individuals of European ancestry, there is a decay in overall performance. And that's not because individuals of European ancestry have more genetic disease. This is just a feature of what the training data is. And this is actually pretty common in many different areas in medicine. You know, in cardiology, we talk about lipoprotein little a, for example. Most of that research is also done in Eurocentric populations, and increasingly there is more data available in non-Europeans. But, you know, we are at least acutely aware of this in human genetics. And sponsors are aware of this, funders, and we recognize the value that oftentimes when you do increase the diversity of these populations, and I'll show you some examples, it does boost the performance of these scores in multiple different ancestries. So the response to this in the US has been the All of Us program. This is kind of initially announced by President Obama's State of the Union address in 2015, where it was called the Precision Medicine Initiative, now morphed into the All of Us research program, which is kind of the Framingham heart study of our generation. And this is across the US, aiming to get at least 1 million individuals. They've started to release data. So we actually recently went back just to say, if it aims to be representative of the US, is it actually representative? We just compared to the US Census. And for some individuals, for some groups, it is reasonably representative. There's actually overrepresentation for some groups, like individuals of African ancestry, but those of Hispanic ethnicity or non-Hispanic Asians actually relative underrepresentation compared to the overall US Census. Some of that was the motivation for developing this new collaborative study with Leta and her group, the Our Health study, which leverages a lot of this infrastructure from All of Us, but does targeted recruitment for individuals of South Asian ancestry, especially a group where there are lots of outstanding questions on the reasons for why they get disease, particularly cardiometabolic disease, and is close to home for many of us. Now, because the data is still growing, we still need to use new methods to start to try to improve performance in multiple different groups, because the patients that we see don't look obviously all like one group. Now, leveraging information from other risk factors, because I said genetics of other risk factors do seem to give us more information on disease beyond just the risk factors themselves and other correlated traits. We use that for a new method, but also increase training data from other populations as well for a new polygenic risk score. Okay. So first, I think an important concept here when it comes to these for polygenic risk scores is that the alleles, the genetic profile for everybody, that's all static. But our interpretation for those alleles continue to improve. So oftentimes, if you read a paper on this, it's very important to pay attention for what that score is when it was developed. Because oftentimes, if that same analysis was done, a year later, 2 years later, you may actually have different results. So here's one example. So, one study that we had first in 2018 was, had some visibility because we observed that there were many individuals with a high polygenic risk score that had a risk that was similar to a monogenic variant. Okay, so individuals with FH on average, 1 in 200 individuals, 250 individuals, about a 3-fold risk for cardiovascular disease. Now, it turns out by a polygenic risk score based on our score in 2018, 8% of individuals, so almost 1 in 10, right, 1 in 11, 1 in 12, had about a 3-fold risk, similar to individuals with FH. Now, with this newer polygenic risk score, 1 in 5 individuals has a risk similar to FH, which is 1 in 250 individuals. And you can get increasingly, higher risk based on, more and more stringent cutoffs. Now, because there is more and more training data that is also available in diverse populations, the performance for each of these scores does seem to approximate similarly across each of these individuals. Interesting observation, and this is common for all polygenic risk scores for the most part, is that the performance is lower in individuals for African ancestry. There are many hypotheses why that might be the case. And that's despite increasingly available training data, but that knowledge is necessary when ultimately applying these tools in diverse populations, is knowing its performance on different genetic backgrounds. Now, people have done prescient analyses already of returning this information back to patients. This is done by colleagues at the Mayo Clinic, Iftikhar Kulo, in their preventive cardiology program. They did a clinical trial of just returning risk information. Okay, they did a standard risk return, which is just a clinical risk score for individual to borderline or intermediate risk for one group, standard of care, and then another group returning that clinical risk information as well as their genetic risk score. Turns out when you communicate risk, what's on the y-axis here is LDL cholesterol. Everybody's cholesterol goes down. Everybody's cholesterol improves. Those who were told that they had a high genetic risk, their cholesterol went down even further. And you might say, hey, look, I told you earlier on that there is an average hazard ratio in statin randomized controlled trials, about 0.85. It's going to benefit everybody, so great. Now, what is interesting is that this appears to be a unique feature in predicting the benefit of a statin. Now, there's a handful of statin randomized controlled trials where when the study got started, they consented the participants for genetic profiling. And so now as the technologies have gotten cheaper, then we were able to go back and then calculate polygenic risk scores. Okay, so far, this aside, based on clinical risk factors, the hazard ratio is the same for everybody, whether you're a diabetic or smoker, hypertensive. Hazard ratio is about 0.8 or 0.75. Okay, the reason why we prioritize statin prescription based on those risk factors is that it raises the absolute risk. So relative risk reduction will be the same, but the absolute risk reduction is magnified just because it's higher risk. That's what brings down the number needed to treat. Interestingly here, the hazard ratio is greater. This is similar to FH. This is actually, at least we have the luxury of doing this within a randomized controlled trial, where the hazard ratio is greater, 0.54. So the baseline risk, the absolute risk is higher. The relative risk reduction is magnified. That further magnifies the absolute risk reduction, and that reduces the number needed to treat the most. And in the end, as clinicians, we're not, or at least I'm not as interested in just refining the crystal ball. I'm using these as a tool to make a recommendation for the patient. The patient wants to know, are they going to benefit from the statin? Are they likelihood to benefit? For them, it's just binary 0, 1, right? If they ultimately don't get cardiovascular disease, either the medicine worked or didn't work, and you would never know, right? So in the end, it's really understanding, convincing yourself that this is the right recommendation, and also educating the patient that this is the right recommendation as well. And this appears to be a uniquely helpful tool in that risk discussion. This doesn't seem to be specific to statins. Actually, this is replicated by others with the 2 completed phase 3 randomized controlled trials for PCSK9 inhibitors. There's very similar interaction that there seems to be a uniquely greater benefit of LDL cholesterol lowering for patients who have high polygenic risk score. Now, all of this work has been really, for the most part, really predicting first events. And most of cardiology, at least subspecialty cardiology, is really in patients who develop cardiovascular disease. Genetic diagnosis and treatment based on genetics is largely in patients who have manifest cardiovascular disease. So recently we've been exploring, is there a role? Is there something that's going to be helpful for patients who already have cardiovascular disease? I would have predicted that it wouldn't, right? Because these are features that are important beforehand. Why would it have relevance going forward? So we did actually a very comprehensive risk assessment where we took all the features together to predict future risk for cardiovascular disease. This metric here, adjusted R-squared, is just importance in an overall statistical model. None of these are great. Turns out we're not great at predicting who is going to get recurrent cardiovascular disease events. But I was actually pretty surprised that a polygenic risk score is at the top. And you may be looking at this and say, hey, this is pretty suspect because things like LDL cholesterol are down here. And the reason for this is, I think, is because once people develop cardiovascular disease, we're all really good at starting to now constrain their risk factors. We bring their LDL cholesterols down to a low and narrow range. We maintain blood pressure. We maintain glucose. It's not perfect for everybody, but at the population level, they no longer become great predictors for predicting recurrent cardiovascular disease. Things that we're not treating rise to the top. And it turns out the persistent atherogenesis from a coronary artery disease polygenic risk score does continue to have relevance here. For individuals who have developed premature events, it does seem to stratify future risk for recurrent events as well, too. Now, this is kind of early work now where we now are starting to look at features related to atherosclerosis. This is largely based on CT angiography. The top one, this one right here, is in an HIV randomized controlled trial, the Reprieve trial. And these are patients just within our biobank who happen to get CTs. And we not only observe that individuals with a high polygenic risk score have more atherosclerosis, a greater burden of atherosclerosis, they also have more high-risk plaque features as well. And there may be multiple different reasons why that occurs, but that may be a reason why they're having worse events and recurrent events as well. Now, how that plays out into clinical practice is still a little bit TBD because we're already very aggressive with these patients. I think the role will be in new drug development, or at least the allocation of more expensive medicines as well, really prioritizing the patients who are more likely to benefit, or at minimum going to be the ones that are going to be the highest risk patients. And as people are also developing and designing clinical trials for coronary artery disease, it is standard practice to enrich for recurrent events to increase the efficiencies of these trials. Actually, the first trial for lipoprotein(a), that phase 3 trial was just announced a couple months ago that they didn't get, likely because they didn't get enough events, is being delayed for at least 1 more year. So it is really important for these clinical trial designs to improve this. And this, at least I've shown, at least empirically, is that this may be a really important predictor in predicting recurrent events. Now, I'm going to wind down here, but we have been focused because the research infrastructure is really focused on middle-aged individuals, and this is the sweet spot for clinical risk prediction in its current form based on age and sex and clinical risk factors. It is actually really hard to really improve beyond that. What I hope we will continue to lean on is the unique feature here is that this is something that is available early in life. And most of this, we're not able to detect early in life. And this might be helpful for identifying the folks who are at the highest risk early on towards more efficient and more effective prevention. And this is like out in the common space. People are attuned to this. People are very interested in this. Now, again, since the earliest cholesterol guidelines in the 1980s, there's always been a recommendation for screening lipids for young individuals to identify hypercholesterolemia, largely focusing on individuals with FH. And I'm not saying we shouldn't do this, but we should think about something that is parallel. As I said, if you, it's a little provocative here, but if you were to do screening polygenic risk scores, you're actually going to find more individuals with that same amount of risk, and individuals who are similarly going to uniquely benefit from lipid-lowering therapies, potentially instituted earlier in life. Now here, this is, because this is not either or. I'm doing this as the comparison of clinical factors and genetic risk factors to really align with saying, these are the reasons why we use clinical risk factors. None of that has gone through a randomized controlled trial, but still makes a lot of sense, but that's the evidence basis. And really trying to develop a complementary evidence basis, but none of these have to be done in isolation. Turns out actually, if you use both of these features together, you do boost prediction for coronary artery disease across the life course, because most of the events that are happening earlier in life, you're not going to detect based on 10-year risk prediction, which I said is very age dominant. That's based on these bins of blue and green, the events that are happening early in life. And then you recover detection of those events if you also add a polygenic risk score. And obviously the polygenic risk score is not going to be as important later in life, right? And so the overall C statistic becomes a lot more stable across the life course if you have both of these features together. And we've been doing a lot more modeling to try to better prioritize younger individuals who are at risk, because on an age-dominant model, you're prioritizing folks in their 60s and 70s. And there are many reasons why folks have not yet developed cardiovascular disease, but you're not identifying folks in their 30s and 40s who are at high risk. And through this modeling approach, even though the younger individuals have lower 10-year risk, we can better identify individuals who have higher lifetime benefit through this approach that uses both genetics and clinical risk factors. And just to really nail it home, like, why is it important to identify the risk early on? Is because, as when you institute a therapy, that benefit from that therapy is really magnified when it's instituted earlier in life. This is actually one of my favorite papers. It's not coming from us. This is a hazard ratio in randomized controlled trials. For every year a participant is in a randomized controlled trial, because I keep telling you this hazard ratio, this overall hazard ratio. That hazard ratio is not a proportional hazards model. For every year somebody is on lipid-lowering therapy, there is greater and greater relative benefit from that therapy. And this is actually modeled based on human genetics. This is lifetime perturbation based on that therapy. And this is kind of a reprisal of this based on more diverse data. Now, separately, beyond the empiric observation, there is something about this, like in our patients and in the population, where people are often compelled when you present genetic information. Many of the folks that are coming to me are coming to me based on family history, and people talk about their families and what is present in their families when they're thinking about their own risk. And so when you present that information back, it can be really powerful in the risk communication, not necessarily to scare people, but really to refine, educate, and advise patients. And this is based on a research study that was actually done in Finland, where a lot of people felt like this would be beneficial. And in that single-arm study, when they returned clinical factors and genetic factors back to patients, the extent to which those were abnormal, each of those influenced the likelihood of changing lifestyle-related factors in an independent fashion. Now, as I said, the infrastructure for looking at young adults is not great. There is one such cohort that's been funded by NHLBI called Cardia. And over a longer time course, we find that polygenic risk score does stratify future risk for cardiovascular disease. And we've started to give this back to patients. This is actually in the context of a research study. And as I said, many of the patients come to us based on family history that leads to, in general, higher polygenic risk scores when we do the test. We're not doing it for everybody, at least in scenarios where we think it's helpful, because folks who come in their 40s, 30s, sometimes in the 50s, the 10-year risk score will not be that helpful if there are other features that really make us concerned, often based on the family history, where, especially if there isn't similar segregation of risk factors. And many of the times we've used this to start statins, to intensify lipid-lowering therapies, and many times we still don't know. We'd use additional factors and tools that are available to us, like imaging. This is an in-house workflow. This is in the context of a clinical trial. I'll come back to that. But we've been very interested in now bringing this into the clinic. As I said early on, I'm now involved in the leadership for in-house genetic testing. So we've developed a panel that I would hope by this talk was going to be launched. It's probably going to be next month. All right, but one thing that is challenging is, like, what score do you use? There is no single polygenic risk score. I'm motivated to use scores that come out of my lab, but like the next day, Ewan's lab or somebody else's lab is going to come up with a better score, right? So how do you have a framework that is going to be robust to this? And it turns out now there's like a pretty good repository for all of these scores. And we developed a method that kind of integrates these scores together so that as somebody develops a new score, we can continually improve an overall single canonical score. And this is important because this is actually, there's a really nice paper in JAMA from Scott Damerar's group at Penn, along with Mike Levin, is that if you just look at any one of these individual scores, there is variability in who is at the top. And when we started doing this, this gave me a lot of pause, and even just ordering polygenic risk scores for these different companies, because we don't even know what algorithms that they're using. They do, some of these companies do publish their metrics, but if there is variation, that does decrease my confidence in the reliability of that score. But we showed when we use this integrative approach that, like, as there is a new polygenic risk score, you not only lead to overall better performance of the score, it does lead to reliability in that classification for our high-risk score. So you can see limited correlation, improved correlations for coronary artery disease and diabetes. We did this for a few other traits. And then the agreement through this framework is much higher as we successively incorporate more information. But also, like, the assay that we use to calculate this, you can calculate a polygenic risk score for anything. Actually, this initial product will be a cardiovascular disease panel. And it turns out that if you test a lot of cardiovascular disease, even though inherited cardiovascular disease in its traditional form is pretty uncommon, in the population, if you do a panel, the aggregate prevalence of high genetic risk is actually pretty high for cardiovascular disease. Separately, it's helpful that cardiovascular disease risk is pretty modifiable, but the diagnostic yield when you put this all together is pretty high. Now, we are also working on a cancer panel. You start to put all these things together, actually these tools will continue to be potentially effective, or at least will be have a high diagnostic yield. So I'll wrap up here. So really, at least focus on a coronary artery disease polygenic risk score. It is obtainable. The root features only need to be assayed to be obtained once. These things do require iterative analysis, and we think that we're approximating frameworks that could be helpful. But there are other paradigms that many other colleagues and us are advancing as well too that we can potentially talk about. And a lot of this is because we continually learn about the genetic architecture. It turns out, as I've given you numbers for different gene regions, there isn't yet an asymptote for any of the cardiovascular disease. It continues to go up like this. For BMI, potentially asymptotic. But importantly, earlier risk identification, I think, will be really important in the prevention for cardiovascular disease that will move us to a framework that is much more effective and complementary to the 10-year risk framework that we're using today. And in the end, primary prevention, what I do a lot of this is, really very much focused in primary care, is really thinking about actionability and risk communication. How do we get the data so that it's most effective and helpful? This is outside the framework of what typical medicine is, right? Patients come in with symptoms, we diagnose a condition or try to diagnose a condition, and then prevent the complications, at least in cardiology clinic. It's really preventing recurrent events or progression of disease. I think here we have an opportunity for preventing that onset in the first place, or a new opportunity. So yeah, I have the privilege of working with amazing people. This is all the work showcased by folks in my lab, and a reason why I continue to be in Boston now, like 17 years later. So thank you. I'll open it up for questions.
Maybe try to get one or so question, if that's okay. Dr. Leeper.
Thanks, Pradeep. That was wonderful, as usual. In this case, lipidology, it's got a medicine or therapy that is essentially free, almost without side effects. How do you think about branching into other forms of primary prevention where there might be more, off-target effects, lipid lowering, blood pressure lowering, anticoagulants, moving into cancer? Can you, model out the risks and benefits simultaneously? Think about like net clinical benefit.
Yeah, so Nick brought up a good point that what we're talking about here for lipid-lowering therapy, there's nothing fancy about lipid-lowering therapy. We have lots of effective and cheap medicines. Can we use this to potentially prioritize other non-lipid-lowering medicines, or maybe even novel medicines as well? Now, the derivation of these polygenic risk scores is completely agnostic to any particular pathway. That is, a strength is that you're using all of the data available to you to ultimately predict cardiovascular disease, but you're getting at, I think, the important point of like, we want to use this to really prioritize what is the right medicine, what is the right preventive strategy. That might not mean all of the alleles together. Ideally, to be able to do that is that you have enough training data in randomized controlled trials. Now, the randomized controlled trials that are orders of magnitude smaller than those polygenic, than the genome-wide association studies, which does make it harder. Ideally, you have other trials available to you that you can replicate in. As a researcher, extremely hard to unlock a single clinical trial to be able to do this. There are many complicated reasons why. Now, we've started to do some of this. Is actually a great example from the TIMI group. They just had a Nature Medicine paper. It was a collaboration with Raj Gupta, one of my colleagues at the Broad, that prioritized, based on his work, that alleles that influence gene expression in endothelial cells might have particular relevance to lipid lowering, potentially. So actually, they parsed out a polygenic risk score based on just endothelial cell-related alleles. And in that subsetted polygenic risk score, they had an even greater interaction and a hazard ratio of 0.34. Hasn't yet been replicated, but at least in the TIMI clinical trials have suggested that. And that's not what I would have predicted. In the end, that's not actually the best predictor for cardiovascular disease, but it seems to be an even better predictor for genomically driven lipid-lowering therapy. So I think we need more data to be able to do it. But I think there could be many different ways to. I have lots of different thoughts, but the main issue is access to data, to be honest.
So we are at 9:02. We do have a lot of questions flooding in online as well. Yeah. But Dr. Natarajan will also be presenting for cardiology. I checked with them. It's okay to promote 8 a.m. tomorrow at the Falk Library. Dr. Natarajan, thank you so much for this. This is wonderful. Yeah.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.